So for a diabetic foot is involved by neuropathic and vascular problems as well as infection. NIV, neuropathic, infection, and vascular. Regarding the neuropathic involvement, this happens when there is a loss of vibration and position sense, which comes first. That's why Sime-Winston examination with a monofilament is indicated. There is sensory dysfunction which leaves the protective sensations, and there is more chance of injury. And there is autonomous dysfunction which leads to drying of the skin and crack propagation. The ulcers are mostly painless, bleeding, and have thick skin changes with hyperkeratosis and punched out base. They are different than vascular lesions, which are very painful. Vascular ulcers which are very painful. The motor dysfunctions will cause imbalance between the intrinsic and extrinsic muscles, causing clot deformities and other deformities. The vascular effect is from large and small arteries, causing painful ulcers which don't bleed and they are necrotic. And infections happens because of decreased neutrophil activity and is mostly polymicrobial. So whenever these patient comes to me at the clinic, I will take a pertinent history of the patient, do optimal examination and check for the deformities. I prefer to classify them into to risk, that is mild, moderate, and severe risk. This helps me to plan further treatment. In the low risk population, there is no risk factor except KLS. In the moderate risk, there is deformity and neuropathy, but no critical leg ischemia. And a high risk population is this which has previous ulcers, previous amputations, are on renal replacement therapy, or have a neuropathy with non-critical leg ischemia. So a low risk, I will have an annual foot assessment. For a moderate risk, I will do a 3 to 6 monthly assessment. And for high risk, I will do a 2 to 4 weekly assessment. Regarding investigations, the patient should have blood investigation, clinical assessment, radiological assessment, and laboratory assessment. Regarding the lab assessment, I want to do HB1AC, which helps me to identify the glycated HB level, which gives the indicator of sugar control within 3 months, and HB1AC of more than 7% is abnormal. Serum albumin level should be more than 30 gram per milliliter, and total lymphocyte count should be more than 1500 per millimeter cube. I can do a transcutaneous oxygen pressure measurement, and which should be more than 30 mmHg around the ulcer area to have a good healing. Ankle breaker excess should be more than, index should be more than 0.45. It is invariably falsely elevated due to the calcification. X-ray will be done for exclude osteomyelitis. Bone scan can be done negative in neuropathic joints and positive in infected cases. And MRI can be done to identify if there is a soft tissue collection. And deep tissue can needs biopsy to assess for further treatment. A treatment is MDT approach. NICE guideline states that it should have a multi-system approach. It should examine the patient for any risk factors like neuropathy, vasculopathy, limb ischemia, ulcers, KLS, deformity, gangrene, and Charcot arthropathy. Regarding the treatment of the principles is to first is control diabetes mellitus, do optimal patient education, do aggressive treatment of ulcer, and arthrodesis are optimally better than open central fixation. Regarding the goals, I want to reduce the deformity, provide stability to the hind foot ankle, and prevent ulcerations. I can excise the divertilated tissue or infected tissue and do a negative wound pressure therapy, minimize the dead space and remove the bacteria, and enhance formation of new blood vessels formation. In a Charcot orthopedy, I can put a offloading cast for the patient, which help accommodate the foot and improve the ulcer healing. Rocker bottom shoes can be advised to avoid offloading. Regarding the surgical release, surgical principles, these patients have tried gastrocnemius and causing equine deformity with increased foot pressure. There should be a prophylactic removal of prominent pressure and bone lumps. Diabetic patients require twice as long plaster therapy than normal population and should be considered more rigid fixation than normal conventional ORIF.